We are live now.
Yeah.
Okay. Very warm welcome, everyone, and welcome to the 16th episode of Tuesday Tea Time with Dr. Kawita Bapat, ma'am, an academic extravaganza. So, before starting the session, I request everyone to please keep your mic on a mute mode and video off so that we can get a better recording. So, let's start the session by welcoming our own Dr. Kawita Bapat, ma'am, Director of Bapat Hospital and one-day hysterectomy specialist. Preeti, please share the CV. Vice President Foxy in year 21 to 22, Director of Bapat Hospital, Organizing Secretary of AICOG 22 in Indore, one-day hysterectomy specialist, ICOG Vaginal Surgery Certified Course Center, Jogi Peer Review.
Thank you, Beta. We will
Thank
do the recording.
Yes, let us not waste
Allow
time.
to share the screen. Please allow the receiver of this. Thank you so much. And I'm starting the recording over there. So welcome everyone today who has joined as a Tuesday tea time. And I'm really happy that the Tuesday tea time is really nice. So many viewers are there. And I'm today very happy that we have Manjula Anagani with us. And the Tuesday time is basically Learn Simply with Kawita Bapat. It's a platform of conversation, insights, and knowledge sharing. And we prefer to give the take work messages and a crisp knowledge about the various subjects through conversation. And most important, with the leaders and experts in their respective field. And number one thing is our goal is to provide a practicing OBGYN to access a valuable information of knowledge, and that can help them to grow professionally and personally. So welcome, Dr. Manjula Anagani. I'm so happy today. You are a highly accomplished person and a renowned figure in the field of medicine, especially in the areas of laparoscopic surgery. You are a Padma Shri awardee, Manjula Anagani, the prestigious Padma Shri award in 2015 with the President of India, and award is given for the distinguished services in a various field, especially into the OBGYN.
Thank you, Dr. Kawita.
Madam is the co-founder of Pratyusha Support, this is because of this Pratyusha Support NGO, it focuses providing the assistance and support to the destitute women. You are a Guinness World Record holder, which holds a record of removing highest number of fibroids from single patients. It's really amazing. I always get impressed by this. And it's an exceptional case. You have successfully removed 84 fibroids. I think this is very great thing. You are a director and head of the department, and you serve as a clinical director into the care hospitals of Hyderabad, visiting laparoscopic surgeon to many more places, especially in Dubai, and showcasing your expertise and reputation on international level. You are also honorary associate professor, Manjula, and a position of associate professor at NTR University. And you have experience of 25 years with academic experience and so many things. I'm really proud to have you receive so many awards, and especially the awards which are very, very important, the Hall of Fame Award, Surgeons of Excellence Award, SRC Association, NMC Dubai, you have been awarded. You have a founder secretary of IIG Telangana and is a pioneer into the gynec robotic surgery. That's another important person because you started it as a first person with this system of called RAS system of the care hospital. So many awards, so many publications, and Manjula, you're accomplished persons, and I tried to minimize the way I could put you in a way. I'm really proud, but the most important thing, a friend of mine for so many years, and really happy to involve you, and on a one call you said yes, so I'm really proud for that. So we are today discussing and having a discussion between you and me that what is the future of what they call is the future of laparoscopic surgery in India. That's our point we are going to talk about. So before that, any opening comment which you like to start, and then we can do the conversation together.
The first thing I would like to say is thank you, Dr. Kawita, and all the best for everything, whatever you want to achieve. And then when we talk about minimally invasive technique, I think initial parts of the way we struggle to get into it is over. Seeing is believing, which people started understanding. It took us 2 decades for people to understand that minimally invasive surgery is here to stay. Either you also get into it or you perish. It is like publish or perish. You similarly, minimally invasive surgery, either you have to get into it or patient is going to leave you and go to surgeries where people are going to do it. So girls, guys out there, the young next generation, your bread and butter is going to be in gynecology, minimally invasive surgery. Obstetrics is anyway going to be there. But apart from it, this is what is most important thing.
So you mean that the current status of endoscopic surgeries in India is growing gradually, and this is a future, either you, the way you have put it.
Yeah. See, in a obstetric case, we always talk about latent phase and accelerated phase. We have achieved accelerated phase in minimally invasive surgery. The latent phase is over. So it is gradual phase is over. So now it's only accelerated phase.
Yeah.
It is like for every hospital is going to have an endoscopy unit. Every hospital you have to do, or your friends are going to do it. That's it.
Yeah. So you mean that it's a very, very important thing. And gradually the conventional surgeries, or you can say about the traditional surgeries, are going to be, because otherwise also, what is the best for the patient? What are the best things of the things? We both know there are so many advantages of endoscopic surgeries over other surgeries. I think I like you to now enumerate few for both, for the gynecologist also and for the patient also, for both the people.
It is not that we will say that open surgeries are going to become obsolete. No, we should be a good open surgeon for us to understand the anatomy, so that fallback mechanism is always there. So if something happens, like a vascular injury, you might have to open and then go and correct it, or a major bowel injury, if you're not well versed with doing it. So when we're talking about advantages, yes, we always divide them into patient advantages and surgeon advantages. Let me first talk about patient, because they are going to demand for us what it is. So first, always patient in previous years, Kawita, it used to be joint families. Right now, we always have only a nuclear family. And now, both wife and husband should work. It's not that ek banaye, ek ghar mein rahe, so they can afford to have a leave. So nobody can afford to have leaves and sit at home. So they need surgeries where fatafat surgery, aapka vaginal surgery jo ek din mein ho jayega, waisa hi karna hai, next day tak surgery hospital mein chale jana. That means they want less infection rates, less bleeding, less post-op complications early and delayed. Means no injuries immediately, because magnification is 10 times. So we would be seeing and coagulating every small vessel which is there. So post-op bleeding will not be there. And also when we are looking at it, दूर तक हम लोग एक स्कोप से लिवर में भी देखते हैं, एक स्कोप में ये भी देखते हैं, जो ओपन सर्जरीज में नहीं होता. So every organ, we will not be missing the target. Means the patient, example, has a pain in the RIF. The pain can be because of appendix. It can be because of a small other gynecological issue. When we go inside, we will know exactly what is the cause, even though when there's a dilemma in the scan. Like today morning, we had a case where the patient said there was some ovarian cyst, query abscess, query that. When we went inside, it was a para-ovarian cyst, which has torsion.
Twisted.
So, twisted. So when we see ovary separately and there is a mass separately with fluid levels, ultrasound, CT, everything can go wrong because it's the man behind the machine. But once we put a scope, you know what it is. And with the minimal invasiveness, with least morbidity and long-term complications of fibroids, the adhesions and even the hernia, all those can be avoided totally. So patient ko to barabar hai, wo aaram se, they started knowing. Pehle to darte the ki thode tukde reh jayenge. Pehle darte the again that complications aayenge. Now they know minimally invasive surgery is good. But for us, what it is, yes, it's a new thing. Learning curve is going to be there. We are not saying no. But for us, what we have to do is we are going to stand and operate. We don't have to bend. First, ergonomically, we have the best thing. Just have to stand, look in the thing and do it. हाथ से हम लोग जो छोटे छोटे चीजें ऐसा करते थे, सिलाई करते थे, लाई तो we make kitchen में जो काम करते उतना ही आसान से हम लोग कर सकते. It is just the replication of what we do in the open surgery into laparoscopy surgery. That's it. Nothing else. So we are going to reply. And also 10 times magnification, like I said, again, we can see every nook and corner. And we can see, and we will see that at the end of the surgery, तसल्ली से सो सकते हैं. अभी vaginal का इसका मेरे को एक ही advantage ज़्यादा रहता है कि vaginal पूरा होने के बाद, you think everything is fine and you come out and we are still having. If the patient has a tachycardia because of pain, we are worried. Is there a small bleeder? Because it's atherosclerotic. अगर इसमें क्या हो जाता है, at the end of it, हम लोग पूरा देख सकते कहीं से भी bleeding नहीं हो रहा, everything we can see and then come back. Other than that, vaginal and this thing we know that both are
No,
almost.
we are not here. We are not here to discuss the pros
Yeah.
and cons about the vaginal.
Yeah, both are good. Everything.
You are the known and a pioneer in your surgeries, and you have made it so much popularized and doing so many good work out of it. So the
It's
question
just a surgeon
the
who is
discussion-
comfortable with it. So for the surgeon, I think what
but discussion here is what is the future of
definitely.
the endoscopic surgery, and there is definitely a great future with not many good surgeons all over India. And ideally, and you are already said that we can do we can do most common endoscopic surgeries right from a small tumor. To
For me, Kavita, what is more important is in emergency situations, in the sense that post-operative, आज कुछ surgery हुआ, cesarean हुआ, 2-3 दिन के बाद, you think there is peritonitis, you don't have to do open surgery again. Put in a scope first to confirm what is happening. If anything is there, if you think it have to be open, then you can always open. Fallback mechanism will always be there. So future, I think even for छोटे चीज़ें जो भी है, it is going to be laparoscopy only. So because the costing is the only difference, which was the main reason why we used to worry. One is the expertise, which people did not have before, which is now everybody is taking up. Second is the cost. Is it going to be very expensive compared to the open surgery? In nowadays, अभी तक तो थोड़ा फर्क तो है ही, but as the number game increased, as the thing, we started doing more and more cases, and the competition has come, and the costing of the companies, the thing has started coming down, and insurance is covering everything. I think we can all do almost at the same price the minimally invasive surgery. And what else we want to see? The patient को एक हफ्ता घर में बैठना है, job को नहीं जाके, loss of pay, और कोई और आके फिर काम करना,
very much cost effective. You mean very cost effective, less burden to the society, and early ambulation and many more things. But being a very common question, though it's not a comparison between the conventional or the vaginal or the future of the problem in this country, we are trying to reduce our maternal mortality. We are trying to reduce we want more obstetricians to work onto it. And the more people to work in the rural areas also. That's basically my thought about our country. And you are working so good with your NGOs in a many more points. But what actual challenges as a gynecologist are facing in adopting the endoscopic surgery, for example, I'm just putting in that way.
See, very, like I said, it is always a learning curve.
Learn curve is another thing. What I'm saying that the challenges is facing is like you and me sitting in a big city. And this country is not only the rural we used to talk about, but nowadays we have a good transport, good systems, we have good communication with everything. But really, do you think that these are the challenges that gynecologists facing to do endoscopic surgery, and not on the rural part, but the closer part to the big cities? Are they able to do? Number one challenge they are facing. Number two, learning is we always talk about the learning. Learning curve, I think if they have an idea, anybody can learn. What I always talk about, you should feel that I want to learn. That's the challenge, but that's not that big challenge as it. Then the availability of all this. So what challenge do you think? Not as a surgeon like you and me, but I'm asking the common gynecologist what challenges they are facing.
But when they can do a lap tubectomy in the rural areas and everything, we can do everything. So when we are not scared of doing a tubectomy, going and doing it, that means infertility is covered. Means हम लोग उतना तो देख सकते हैं कि क्या हो रहा है, pregnancy क्यों नहीं आ रहा. Then ectopic is also covered. When you can just go in and then do tube to cut हुआ तो tube तो निकाल भी सकते हैं. So you can do that. Majority of the cases like ovarian cyst, infertility and sympathy कर सकते हैं. So ये जब हमारे को आदत आ जाता है, when we can do, when the anesthetist gears up and we can do it, then slowly hysterectomies can come. So depending on the setup, we can go ahead. So it is not that we cannot do. There is availability. When you said availability of basic laparoscopy is done by everybody, every hospital, PHC nowadays in the government. But if you want harmonic and all, agree. That is the issue. But you don't need that for majority of the surgeries which we can do. Even in robotic, when we are using bipolar and scissors only, I'm sure we can do that with even laparoscopy itself. So it is us who is deciding our inhibitions, our unpreparedness, which is the challenge.
And that's what I'm saying. If you are not ready and not ready to learn, that's a big challenge, can be. But otherwise, at different places.
Availability is there. when tubectomies, this camps happen there, we can
Yeah.
do this. also.
Almost
Added-
40 years back.
Yes, added incentives. If the doctors are going to get by taking this thing, added incentive, that's when I think if it is always salary based and it is like I'm directly telling you and say that tum kare to bhi utna hi dete, ye bhi kare to bhi utna hi dete, then definitely it lies in the onus of the surgeon that whether they want to do or not.
Yeah, absolutely. So the challenges faced by the gynecologist is learning is okay. But if with a minimum instrument, they can adopt and they can start doing endoscopic surgery at any part of India if they really want to.
And then it could be hybrid surgeries कर सकते means
Yeah.
ऊपर का जो 3 ligaments है वो laparoscopy से करो, बाकी सब नीचे से कर लो.
And then not only the hysterectomy, I am talking about several other things they can be. They can do the C entry, they can do many more.
Yeah.
Everybody we need not to be of level 3 surgeries.
Section.
Level 3 surgeries, we are not talking, we are talking about the primary level surgery.
Anything can be done.
But the major problem which I see and I feel about the role of training and education in promoting. See,
Yeah, I will tell you that. I will definitely agree with
the question is like that. A very small class is doing extraordinary surgery. So very, very point something. And the mediocre people are also doing many more laparoscopics. I'm not blaming them. But when the role of training and education come, the main important problem which I see in this country is there is no proper curriculum. They have developed their curriculum. They don't have the syllabus. They don't have the simulators, which is needed all the time over there. Or I'm not going into negative. I'm just asking you how we can improve the training and education.
But, yeah. Let me tell you, put it something. First thing is knowing where it is happening. Also, people do not know. So that is also awareness is not there.
The knowledge.
Knowledge that from where the training, exact training is happening. Most of the places it will be 1 week and 3 days and they think it is done. No. So first of all, let me put it one thing. One, the bodies, that is FOXY and ICOG and the university-based training programs are there. FOXY is 15 days, ICOG is 6 months, then university-based is 1 year PDCC program, which we have with the NTR University, now Kaloji University. So there are centers in India which have a 1 year fellowship, postdoctoral fellowship, then 6 months ICOG fellowships and 15 days. So doctor who is interested should go search which centers, then see where the hands-on training is there, where academics plus the number of cases are more, or not just the theory which you can read. That is one.
The volume should be more.
Should be there. Then the next thing what is important is there is industry. When I say industry, it can be J&J, it can be Medtronics, it can be any company. They do the advanced laparoscopy training, on-site training programs, 2 days, 3 days, where for people who are already doing basic, to see the techniques, different techniques, they come to our centers to see the surgeries live so that they can adapt. So they should next level go into this. Next, we should also not forget the proper training centers which have wet labs like CMAST. Then you have Johnson Johnson. I see this thing in Chennai and even this thing. And we also have Medtronics training centers. So we have all these training centers where again 3 days, pelvic trainer, simulator, plus the wet lab on the pigs will be there. Okay, it's not that they're not there, but people have to understand they're there. And depending on their level, they should first go and get a wet lab training, then go for human body training, looking at the 5 FCOG, ICOG and this thing. So we need to understand simulators. There are few in the India. One we have in Hyderabad, one we have in CMAST again, in MAST that is now and all that. So I am in minimal invasive surgery. I am more in favor of pelvic trainers rather than the simulators. Simulators को hand-on proprioception feeling नहीं आता, but simulators are very good for robotics. Okay, so what is important is pelvic trainer, because partial proprioception is there in laparoscopy. It is always the pelvic trainers which give you the feeling. But pelvic trainers के बाद it is a wet lab. Do the surgery on the pigs or whatever, or cadavers or whatever it is. Then come on to the human being and do. So there's a methodical training should be done. Like you said, syllabus should be there. We made the syllabus for ICOG, which you know we all do it. Then we also have a syllabus for a 1 hour courses also. So syllabus is also made. Exams are there. We have our our yearly PDCC course has a proper theory plus practical exams where they're done. So it's not that it is not there, but what happens, Kawita, is after MD, people want to settle.
Yeah.
They don't want to take another 1 year, another 6 months.
No, not at all. Because they have already given so many years their life.
And so they think that और 1 साल वेस्ट कर 3 साल लगे ओपन सर्जरी सीखने के लिए तो
Yeah.
लैप्रोस्कोपी सीखने के लिए 1 साल तो लगाना है
तो देना
6
पड़ेगा।
महीना तो भी लगाना है so training facilities are there it's not it is not there but we need to it is like beauty is in the beholder of the eye you will see that it is there only when you start searching for the right thing
Amazing. I totally agree with you. I
and so
totally
start
agree with you.
go get trained then when you do it so for me I would like to put one formula here right which I say one is always technique you learn see the masters and learn the techniques
Yeah.
second the training you should be trained in a stepwise manner rather than jumping from the first step to the third step
Others.
third understand minimally invasive surgery another hindrance or challenge is forming a team you cannot keep changing the team. You should have your assistant who is showing the camera, the regular person. Then you should have somebody for the nurse who's got trained to how to give the instrument, what instruments to give, and vaginal and all that. So third will be the team which you make. Fourth would be the you start teaching again. When you start teaching people, that's when you learn more and more.
Correct.
So technique,
It's an adage one.
Yeah. And as you go along, improve your technology. In the sense, नया technology जो आता है वो अपनाना है. Starting में तो नहीं ले सकते, it's very expensive. But as and when go, which is for the best outcome for the patient, and take the technology. Finally, I think laparoscopy will teach us temperament.
Yeah.
To be patient where it is necessary, because you cannot just do whatever you want to do. We will end up with complications.
Oh.
So our temperament is the one which will make us a successful surgeon. So if you do all this, so I feel that not just the future of India, future of this technology.
This is going to stay, and this is the way it should be, and that's the reason we are doing the discussion. This is the future of India. It's not like that we're not discussing about it, but I just want to know that adoption of endoscopic surgery, and we all agree that the impact on the healthcare cost. Healthcare has got, because lot many insurances will come, lot many hospitals will adopt, lot many technologies will come. I think next 5 years, where you see that each and every person will be get operated by a laparoscopic surgery, or what you see, where you see it.
99% would want laparoscopy first as a fail-back technique. Open will be there, fail-safe. Means if necessary, when they cannot do finish or they feel that some complication is happening, that's when they would open. But otherwise, I feel the youngsters are really coming into laparoscopy.
More
I appreciate
and, and they should come because it's a future.
I really appreciate them that there are two things which is happening in the youngsters now. One, they're luckily for them, the teachers are there to teach. Second one is the training facilities have improved. So with these two, if their attitude is right, then I'm sure they can go to whichever altitude they want to go.
Okay, so I agree with you that this is the point which is very important, that they should have a correct training, knowledge, and do one, show one, do one, learn one, teach one, everything. I agree with you. All the points. I agree with you. But as a concluding point, which I like to, you're doing a great job by teaching people. So just a question, and it's not something which is unusual to talk about. It's really the individualized technique and the specialized technique they develop by themselves, they teach also people. But we definitely need some standardization. See, we have,
agreed.
And we have some accreditation and standardization when we talk about this type of courses, and the courses should be available to all. That's another important point, that only that one class of the students are able to learn, or some.
Dr. Kawita is off.
Yes, I guess, ma'am, there's some.
I will start continuing in what Dr. Kawita was talking about. Accreditation is the most important thing. That is the reason when I said ICOG providing FOXC accreditation, ICOG accredited courses, then we have university accredited courses, which we talk about. Individual person will not make a difference. They do not have any standing in the legal thing. So in spite of you having anybody having MD, MC, MS courses, unless you do at least 30 surgeries of any particular thing, you are not called as a master. The same way, unless you, like Dr. Kawita said, see one, teach one, do one, the same way, then only we cannot, we will not be able to do it.
Right, ma'am. Ma'am, we'll wait for her to join again, and then we'll start.
Yes, we will wait for her to join back. ये सब नया टेक्नोलॉजी जब आते ना ये सब challenges रहते techniques, and when we are looking at these are all the
Yes.
AI and newer thing, the electricity bumps when we start recording all those things, when we start editing videos, the network issues, but we have to
Yeah.
adapt to the technology and then move forward.
Do you think there is, ma'am, is there any legal requirement for starting laparoscopic surgeries? Is there, if there is a litigation or some problem, what
No.
training you need to produce?
Right. See, the point is that with MDMS, definitely everybody is supposed to know laparoscopy. You can go ahead and do. You don't need legal for it. The legal comes when the complication comes. How many surgeries you have done is something they are. So minimum of 30 surgeries of a particular type you have done before. Usually there will not be any. You were supposed to be knowing that. So when you're doing an advanced surgeries or anything, that's when all these things. When you get a proper training, there'll be only added advantages. In spite of us doing 3 years of PG, if you have a complication, yet still ask us about on what credibility you have done. Any complication comes, we have to own up. The same thing happens legally. Whatever said and done, it is case-based discussion. But if you have these certificates, they will be of some use to say that yes, I have been trained by this, and after that I have done. मैं कितना करी, वो important है. And under supervision कितना करी, and हम लोग अलग कितना करें, वो important.
So self-restraint is important. Till you are highly competent, we should be able to do, call a senior, bring someone. Yeah. And another is counseling and consent should be very taken very properly, especially for laparoscopic surgery.
And to know when to stop, in the sense, depending on our expertise, we should be deciding when to make it into open, and instead of going and then taking too much of aggressiveness and then thinking that my laparoscopy mein hi karungi, and then in spite of complication, in spite of getting stuck, having the ego not to call a senior for help or a colleague for help, and not turning it. If we have, that's what I said, it's our attitude which is going to make a difference. So if our attitude is in the right place, with only the safety, we have only two rules in laparoscopy: safety of the patient, comfort of the surgeon. That's it. So if we have the best interest of the patient in our heart, and we do it for whatever is the best for the patient, then I think everything goes in the right way.
And if we have taken proper consent and prepared the patient that we may go for an open surgery if need be, I don't think the patient will come back.
That is one more thing. On the topic of consent, I would like to tell that especially in infertility, majority of consent issues will come. So just don't go ahead and do whatever surgery you want to do just because you see inside. So when we do a hysteroscopy, laparoscopy for infertility, we tell them we do CPT, see and proceed. If we have a para-ovarian cyst, we are going to remove it. If you are going to do a 4 drilling, then you do a PCOS, then you do a drilling. Then if you are doing ovarian cyst, we are doing an ovarian cyst. You should write there. Without the patient consent, you do any procedure that is legally not bound, and you're going to end up with if you have a complication, then you are definitely goes into criminal into that, even though it is a civil case. So that patient can always, like we had a lot of cases where patient has complained that on the table ovary was removed without her consent. Husband has signed, but we don't know what family issues they will have. So husband's signature will not hold true with any organ removal of the patient. So all that is, everything has to be described to the patient. Like I was just talking about this para-ovarian cyst case, twisted ovary in the morning today, which we did. So before the CT scan also, it was not very clear what we are dealing with. So we told her very clearly, if it is a TO mass, I'm going to remove a TO mass if it is TO mass. So then the tube and the ovary will be removed. So all that consents will be taken. Yeah, we are not going to remove a normal ovary, definitely, but the consent has to be taken by the patient before the surgery. Plus or minus, plus or minus, plus or minus, plus or.
Yes. So, what do you think? Ma'am has joined?
No, ma'am. Actually, ma'am's electricity went off, so she will not be able to join again.
Then we'll wind up. She's trying to call me. Okay.
Okay.
Bye, beta.
So should we wind up?
Yeah, I think.
Okay. So. Thank you very much, ma'am. Anything more you want to add, ma'am?
For joining.
No, I would only want to tell everybody. I will only tell everybody, please, all the best, and never let anybody decide your future. You are the master of your future. You should know what you can do, what you want to do, but the heart in the right place, mind in the right place, and your attitude and gratitude is the one thing which will take you a long place.
Thank you very much for your words.
For joining.
We appreciate your presence here. Thank you very much. Thank you. Bye. ठीक है, Richa?
Yes, ma'am.
Okay, bye.
We will